Hello, in this chapter we will discuss cleft lip and palate, their etiological factors and their management. They are congenital deformities that heredity is the main cause of them. Cleft lip and palate can be associated with each other or can be separated. So we may have cleft lip with or without cleft palate, and we may have an isolated cleft palate by its own. It can be unilateral or bilateral. So heredity with superimposed environmental factors are considered to be the most probable cause of the cleft formation. It can be non-syndromatic or syndromatic, which means that they are associated with other body syndromes. There is over more than 300 syndromes that are associated with clefts. However, they are rare. The most common syndrome that is associated with this cleft is the velocardiofacial syndrome, where we have a facial and heart or cardiac defects, and it is featured with a cleft palate, cardiac defects, facial appearance, learning problems and speech, feeding problems. There is some genetics numbers that must be taken into account, like there are 40% of cleft lips. They can be with or without the cleft palate is genetic in origin. But there is 20% of isolated cleft palates that are genetically determined. That means that genetic has more effect on the type of cleft that is associated with lip palate cleft. The syndromes that are associated with these cleft is the Crouzon syndrome, the Down, the Pierre-Robin syndrome, the Treacher-Collins, the Van der Waals syndrome. What are the environmental factors in association with heredity that can affect the formation of the cleft lip and palate? During the pregnancy, if there was an excessive concentration of circulatory substances such as alcohol or certain drugs like antibiotic, steroids, or insulin, that may affect this type of thing. Viral infections, exposure to radiation, and vitamin deficiencies may contribute to the cleft palate formation. Now, what is the associated problems for this? We will get dental problems, and these dental problems are featured in lateral incisor on the cleft side that it may be absent, or we may have a supernumerary teeth. We may see a fusion of teeth, enamel hypoplasia, and anterior or posterior crossbite. Also, we will find some occlusal problems. How is this? There will be an alveolus and palate invariably that will show malocclusion. So we will see a discrepancies in the size, shape, and position of the jaws that is associated mostly this type of the palate, the cleft palate, is associated with class 3 malocclusion where we have a hypoplastic maxilla, which a lack of development of the maxilla, and a prognatism of the mandible, which means an excessive growth of the mandible. So this retardation of the maxillary growth will contribute to the development of the malocclusion. Also, when some wrong early closure of the cleft palate is done, a scar is formed, and this will retard the growth and development of the maxilla. In consequence, we will see that there is crowding in the arches. Also, there will be feeding problems, nasal deformity, ear problem, speech difficulties, and of course psychological problems. For the nasal deformity, patients with the cleft lips exhibit deformities of the nasal architecture, when especially when it extends into the floor of the nose. So plastic surgery of the nose can be done at later age, and treatment after the correction of the cleft. About the ear problem, and this is interesting, we know that the soft palate has an associated muscles that elevate it, and they are close to the auditory tube. Their function is allowing the auditory tube to be open into the nasopharynx when there is a pressure to maintain equilibrium. So when there is a cleft in the soft palate, these muscles cannot do this function, so there will be no space for drainage for the middle ear, so there will be a more susceptibility of middle ear infection, where fluids can be accommodated and bacteria will cause this kind of chronic media infection, which will develop as hearing difficulties in the patient. What about the speech difficulties? Also, we know that speech is a contributed action from the tongue, lips, and the lower jaw and the soft palate that all work together. The soft palate is raised during speech, preventing air escape from the nose. So, the soft palate functions as a valve to control the distribution of the escaping air between the oropharynx and the nasopharynx, which means that it is lifted upward and posteriorly to close the oropharynx and only force the air to go to the nasopharynx only. So this is called the valopharyngeal mechanism, where the soft palate is elevated toward the posterior pharyngeal wall by contraction of its muscles. And when there is a cleft, the soft palate cannot function, gets disturbed. So there will be no contact with the pharyngeal wall, and this will result in escape of the air into the nasal cavity, producing an hypernasal speech. Its function is to prevent the air to escape through the nasal cavity. This will produce what is called a hypernasal speech. Also, when there is a hearing impairment, it will further aggravate the speech problem. It needs several years of speech therapy to achieve an appropriate speech mechanism. Now let's discuss the management. It is divided into stages. The first one is the pre-dental or the pre-surgical orthopedic stage, where we add what is called the obturator that covers the hard palate defect and a soft acrylic extension is used to cover the soft palate defect. This is worn and this is the unworn device. We use this because we cannot do any repair for the lip before 3 months, and we cannot do any repair for the cleft palate before 9 to 18 months of age. So this device aids in feeding. Another approach is the extraoral strapping. This is it, and its main objective is to reposition the premaxilla of the jaw by applying pressure from the extraoral strapping when the appliance, the obturator, is worn inside the mouth. After that, during the deciduous dentition, no orthodontic treatment is carried out because there is a limited advantage at this stage. During the mixed dentition, the permanent incisors may erupt into lingual occlusion, and this should be corrected if feasible, but may be delayed until the next phase of development. So, what is the best time of doing treatment is during the mixed dentition, where a secondary alveolar bone graft is performed at age 10 to 9 years, that we take it from the canculus bone from the iliac crest, and it is placed in the alveolar cleft. It facilitates the eruption of the permanent canine and allows alignment of the teeth and improve the vestibular anatomy. What about the permanent dentition? In this phase, the cleft is not if the cleft is not associated with the skeletal discrepancies, then conventional fixed mechanotherapy is taken. This we are applying a quadri helix expansion device, and this is the fixed mechanotherapy. But unfortunately, there is a significant proportion of the cases that have a severe skeletal class 3 pattern, which means that if you want a full correction, surgery must be taken in place using the Lefort osteotomy. Prior to the surgery, we do a fixed orthodontic treatment where we try to treat the incisor relationship to get an appropriate final results. Thanks.